the Center for Patient-Centered Outcomes Research in the Elderly, which was established through Dr. Gimm Goodwin's R24 grant during the lecture today. And as you know, the series itself, the Health Policy Series, is sponsored by the Office of the President, the Office of Health Policy and Legislative Affairs, the student chapters of the American Medical Association, and the Texas Medical Association. So on behalf of all the sponsors, I'd like to thank you for coming and let you know that you made a wise choice. I see Dr. Ramers here, so thank you for co-sponsoring this. So today we have Dr. Gilbert Gimm in here, and today he'll discuss his work on the mixed methods evaluation for the CareFirst Patient-Centered Medical Home Program. So Dr. Gimm is an associate professor in the Department of Health Administration and Policy at George Mason University in Fairfax, Virginia. He got a BA in economics from, I hope I'm saying this right, Harvard? Is that? And then he got an MBA in healthcare management and a Ph.D. in health economics and policy from the University of Pennsylvania. So his research interests include, in his research program evaluation, disability and aging, care coordination models, healthcare payment reforms, and back in the day he dabbled in the effects of malpractice claims on physician practice patterns, which is quite interesting. Currently, he's the co-PI for the evaluation of the CareFirst Patient-Centered Medical Home, like I told you, to the Blue Cross Blue Shield of Maryland, and so that's what he'll be discussing primarily today. Previously, he was a senior researcher at Mathematica Policy Research in Washington, D.C., where, among other things, he evaluated the Medicaid buy-in program for the Centers for Medicare and Medicaid Services, and he also examined the financial performance of rural hospitals in response to the Medicare payment reform. So he's got a really diverse history in terms of healthcare policy before we all went wild with it here recently. So needless to say, he's widely published in high-impact journals, so we're definitely honored to have him visiting today, so please join me in welcoming him to the island. Come on up. And then one last thing, if you could remember to silence your phones while he's giving his show. So.
All right, can you hear me in the back row? Okay, well, welcome to the island. That sounds quite friendly. I wanted to thank Dr. Graham for inviting me to come here to present this lunchtime seminar, but also to thank him for the wonderful weather. 65 to 70 degrees is quite a contrast to the 34 degrees and light snow that I experienced yesterday. So thank you on both counts. As Dr. Ray mentioned, I'm Gilbert Gimm, an associate professor at George Mason University, and I'm delighted to share with you some of our recent findings from a program evaluation that we did of the CareFirst Blue Cross Blue Shield Patient-Centered Medical Home Program. And we used mixed methods, which I'll talk about briefly. Just to get a show of hands for the audience, if you are UTMB faculty, can you raise your hand, please? UTMB staff? Okay. UTMB students? Any physicians? And any nurses? Okay, great. That's helpful. As Dr. Gray mentioned, my dissertation was on the impact of malpractice claims. And asking if there were physicians in the audience ahead of time was helpful. So today I'll just talk about the research questions. I'll highlight a little bit of the experience related to Mathematica policy research that's relevant to program evaluations, the research questions that we addressed using this mixed methods approach, the patient-centered medical home model itself, and then I'll describe to you the program elements in the CareFirst Blue Cross Blue Shield program. Some of the data sources and methods we used, first from the claims data analysis, which is our quantitative assessment, and then secondly, our qualitative analysis. Some of the key findings, and then discussion and implications from our research. So just very briefly, I finished my doctoral degree at the University of Pennsylvania in 2005, and then worked for a nonpartisan think tank, Mathematica Policy Research, in Washington, D.C. And it was there, Mathematica does lots of program evaluation work for CMS, the Department of Health and Human Services, and that's where I first became exposed to using mixed methods. And have applied a lot of that learning to the evaluation research you'll be seeing today. I then joined the faculty at George Mason University in 2011. The DC area has a lot of Georges. There's Georgetown, George Washington University, George Mason University. This is the third of the Georges. And built upon some of the work I did at Mathematica on program evaluations, expanded to research on the intersection of disability and health policy, care coordination models, of which the patient-centered medical home is one example, and then lastly, health payment reforms. So I just wanted to acknowledge I'm currently the Deputy Director and Co-Principal Investigator of the project, but there's a large team here. Len Nichols is a senior faculty member and is the PI of the project. We also have, importantly, Dr. Jay Want, our physician advisor on the team, and Margie Roden, who's our nurse consultant and also faculty member involved in the evaluation. This project was supported by a 5-year, $5 million evaluation research contract from CareFirst Blue Cross Blue Shield of Maryland, and it's ongoing even today. So the main research questions that we tried to address were these three. We had some additional ones that were supplemental. But the primary research questions were, did the PCMH program have any effect on total cost of care after 3 years? And the short answer is yes. What were participating providers' overall views of the PCMH program? Stay tuned, that's hard to explain in a short sentence. And which PCMH program elements were most and least useful for providers? So the first question uses a quantitative approach, claims data analysis, to look at whether participating in the PCMH program relative to a comparison group altered outcomes. And then the second and third question involve a qualitative assessment, a different approach, and hence these two approaches constitute our mixed methods. So CareFirst Blue Cross Blue Shield is the dominant 800-pound gorilla in the Maryland private commercial insurance market. And I just showed you here, it spans the entire state. From Baltimore, which is roughly north of the Howard County area here. There's a rural part in the eastern shore and a rural part in the western area. CareFirst also includes the District of Columbia. So CareFirst is the main provider for the federal employee program, and a short sliver of Northern Virginia. But by and large, CareFirst's main market area is the entire state of Maryland. So how many of you are familiar with this term, patient-centered medical home? Just a minute. Okay, so about a third, about a fourth of you. So I'll just give a little bit of background. The broader context of payment reforms, with the passage of the MACRA bill last year, Medicare physician payments will change after the year 2020, depending on whether an individual is part of an alternative payment model. And a patient-centered medical home, along with ACOs, or accountable care organizations, are two examples of that. So the first context for health policy, a lot of researchers have mentioned that the fee-for-service payment system by itself tends to support a fragmented delivery of health care, meaning it doesn't provide a strong incentive to coordinate care because of the separate streams of payments that go to different providers. One of the aims and objectives of the patient-centered medical home is to improve care coordination to both enhance quality of care and bend the cost curve. However, in a recent study by Debbie Pikus in 2012, and Debbie is at Mathematica Policy Research currently, Debbie took a look at rigorous studies. There were over 400 of them, and selected 14 that included a comparison group and at least 2 data points in time, and found mixed evidence. So from her paper in 2012, of the 14 evaluation studies that were conducted from 2000 to 2010, a few showed reductions in cost or emergency department use. A few showed higher costs, but others were inconclusive. And so part of the reason for this mixed set of findings in the patient-centered medical home literature is that there's wide variation in patient-centered medical home models, both in terms of how they're set and what elements have been included in these models. So one example of a more recent study comes from Mark Friedberg et al. In 2014 from JAMA. This was a multi-payer pilot in Pennsylvania in which practices received NCQA certification, the National Committee on Quality Assurance, and found there were limited associations with quality improvements and no association with reductions in hospitalizations, ED use, or total costs over 3 years. In the sample, there were only 32 primary care practices that volunteered to participate, and these were included in the pilot study conducted from 2008 to 2011. And this was a very influential paper in establishing that there didn't seem to be a strong association between implementing patient-centered medical home through NCQA certification and bending the cost curve or reducing use of services. In the following year, an important paper that came from Guy David, who's actually a health economist on the faculty at the University of Pennsylvania, was published in 2015 in the Journal of Health Services Research. And his finding was a little bit different. In his study, he found that among chronically ill patients, practices that had a transition to patient-centered medical home status was associated with about a 5 to 8% reduction in ED utilization. The largest reductions in ED visits were concentrated among patients with diabetes and hypertension. And the other interesting thing that came from the paper was that if he isolated the analysis to patients that did not have chronic conditions, there were no effects whatsoever. And that's important because some of the earlier studies have not necessarily made that distinction in the study populations of their research design. The other difference is that Guy David's paper included data from approximately 460,000 Independence Blue Cross Blue Shield patients. Independence Blue Cross Blue Shield is the primary plan in Philadelphia serving southeastern Pennsylvania, and that were enrolled in 280 primary care practices which converted to PCMH status between 2008 and 2012. So a similar time period as the Friedberg paper, but of course with a more robust sample in terms of the number of primary care practices that were included in the study. So this NCQA patient-centered medical home criteria, for those of you already familiar with this, this is an external certification body, kind of like a good housekeeping seal of approval. So for primary care practices that are interested in obtaining this accreditation externally, they pay NCQA a certain amount, $15,000 to $30,000. They receive a checklist, and they have to sort of cross the checklist to show that the practice meets certain structural components to receive NCQA status. So here's just an illustration of some of those measures that are part of the checklist. The first is patient-centered access, which means accommodating patients' needs during office hours as well as afterwards, providing information about the medical home, offering team-based care. Team-based care is defined as engaging practice team members by providing this information, meeting the cultural and linguistic needs of patients, and offering team-based care. And then population health management, collecting and using data to track patient trends, use of hospitals, use of other types of ambulatory services over time. And rounding this out with the last three criteria, there's care management and support, using evidence-based guidelines for preventive, acute, and chronic care management, care coordination and care transitions, being able to track tests over time, referrals to specialists, and care transitions. So if a patient, for example, is discharged from the hospital, oftentimes a primary care physician is not aware of the discharge until many weeks or months later, if at all. So the patient-centered medical home seeks to provide that information to bring it back to the primary care physician office. And then performance measurement and quality improvement, so using performance and experience data for continuous improvement. So these are kind of the broad elements of how NCQA defines a patient-centered medical home based on this Good Housekeeping Seal approval. The CareFirst program is quite different, so let me talk about that. So one major difference with the patient-centered medical home program of CareFirst, first of all, it's a voluntary program, so this is not a randomized controlled trial. Primary care practices had to have the option of choosing to participate in the program. But the second important difference is that NCQA certification, that Good Housekeeping Seal of Approval I mentioned, was not a mandatory requirement to participate in the program. And that's what's a little bit novel from some of the other payer-based patient-centered medical home initiatives. The upshot of that was more small practices were amenable to joining the program because smaller practices that are resource constrained have found it more difficult to obtain NCQA certification based on recent literature. So the CareFirst program consists of a bundle of many different services, but I wanted to highlight three important program elements that are salient to our evaluation. The first was financial incentives. So primary care providers in Maryland, the District of Columbia, and Northern Virginia, if they agreed to participate in the CareFirst patient-centered medical home program, they were able to receive an initial 12% fee bump for simply participating in the program. And that fee bump stayed throughout the duration of the patient-centered medical home initiative. There were also annual retroactive payment bonuses, what were called outcome incentive awards. So after a year, if the total cost of care growth rate attributed to participants fell below a target level, participating providers would receive a bonus at the end of the year. There's some arguments about whether that's effective because a lot of time had elapsed before the bonus was received. The second, and arguably a very critical program element, CareFirst paid for external nurse care coordinators and offered this to the primary care practices at no cost to the practices. So this external staffing support, the nurses would come in and follow up with a selected number of patients who had been identified as having multiple chronic conditions. The nurse care coordinators would then work together with the primary care physicians, and in particular the physician leader within the practice, to develop a customized care plan for those select number of patients. And then lastly, some information was provided through what's called a Searchlight data portal So primary care physicians who participated in CareFirst program could receive access to information on downstream referrals, so costs, for example, of specialists who had been referred to, hospitalizations at the end of a 6-month period, and convey this information back to the primary care physician. Often, this is information not readily available, and so this was an additional program element that CareFirst sought to provide. So in terms of our program evaluation framework, we started with an assessment of some of the baseline characteristics of participating providers, the timing of the implementation of various program elements. So the PCMH program was launched in 2011, and it's ongoing even today, and included some of these elements, in particular the nurse care coordinator and the Searchlight portal. The timing of some of these elements, however, varied, and both were not available right at January 1st, 2011. In our qualitative assessments, we were interested in whether this resulted in behavioral change or engagement on the part of the physician or the provider with respect to communication. Was there follow-up after hospital discharge? Was there use of the Searchlight data portal? How was this program received once the participating providers signed on? And then lastly, we wanted to see what the program effect was in terms of the impact on cost and quality outcomes. The total cost of care is what I'm reporting in today's presentation. We're currently looking at some measures of preventive screening use that we hope to publish by the end of this year. Okay. So with the mixed methods, there are two components. I'll start with a quantitative component that uses the claims data analysis, and then move to the qualitative component that included focus groups and interviews. So for the claims data analysis, we use CareFirst's own medical and prescription drug claims data for working age adults, 18 to 64 years old, because this is a commercial population. That was the principal target for the PCMH program of CareFirst. These individuals had to be enrolled for at least 3 months between 2010 and 2013. So we were interested in looking at the year before the program launch occurred, and then the 3 years subsequent, including 2011. Our treatment group, so those patients who could be attributed to participating primary care providers, represented just under 593,000 patients. And then our comparison group is just under 630,000 patients, and they were attributed to the non-participating providers in our sample. I don't know if any of you have worked with raw claims data, but it is quite a challenge. There were, in some cases, duplicate records. Certain fields were missing, and we had to go back to CareFirst several times. It took almost 1.5 years to create a clean analytic file that could be used. So a word of warning to the researchers out there, if you can work with Medicare claims data, that's great. Private claims data can be challenging to work with. The other step we followed, which was consistent with the literature, the studies in particular by Guy David and that of Mark Friedberg, was to use propensity score weighting. So we used our software to try to make the observable characteristics similar across the treatment and comparison groups, so that any differences in these observable characteristics would not confound any effects, program effects that we would identify. So I'll show you the results after we applied the propensity score weighting to our sample. So this is the treatment group, the 593,000 PCMH patients, and this is the comparison group, the 630,000 that were attributed to non-participating providers. So the mean age, 43 years of age, 44, after we did the propensity score weighting and adjustment. Our sample was 56% female patients, 54% in the comparison group. No chronic conditions was virtually identical. The one chronic condition and then two or more chronic conditions, pretty similar across the samples. There were a variety of regression models that we ran, pulling up different covariates, but I'll show you the final version translated to whether there was an effect on the total cost of care on an annual basis on the next slide. So this is our main finding from the multivariate analysis on total cost of care, and we translated the coefficient estimates from the regression to a year-on-year change in what's called the total allowed amount, and this is a CareFirst specific measure of total cost of care or expenditures for medical claims plus prescription drug claims during this period. And what you can see is within the patient-centered medical home patients, if we look at just all members, relative to the comparison group, after the first year of intervention, there was a reduction relative to the comparison group of $38.40 over a year. And then in intervention year 2, we saw a slightly greater difference, about $150, and that finding was statistically significant at the 0.01 level. And then intervention year 3, that difference also persists. So it sounds impressive. We found a small but significant result. But I did want to give you the 2010 mean spending per member per year amount as a reference. So this is really, about almost a 3% change. So it's pretty small, but it is statistically significant in year 2 and year 3. One of the other things we did, we also restricted the sample to working age adults who had chronic conditions only, so removing the no chronic conditions group. And nicely, as we predicted in our hypothesis, we saw a greater difference in intervention year 1, intervention year 2, and then also intervention year 3 relative to looking at the entire sample. And not surprisingly, the mean spending per year, that year at $5,000, is a little bit greater when we included members who did not have any chronic conditions. So graphically, we also represented this, if you prefer pictures, a regression-adjusted total amount per member per year. So the PCMH line represents our treatment group. This is before the intervention. So the blue trend line is here, and then the comparison group is the red trend line. And you can see that the difference widens in year 2 and year 3. So in terms of some of the implications and main findings from this, we found that the CareFirst PCMH program was associated with a small, significant reduction in the total cost of care in year 2 and year 3, but not in the first year of implementation. So from our findings, this suggests it may take 1 year or more for patient-centered medical home program and behavioral changes to take effect. The complexity of trying to have external nurse care coordinators visit a primary care office to establish a relationship, a trust, to identify patients with multiple chronic conditions who would be good candidates is a multi-step process that took quite a long time to implement. And that came through also in our qualitative assessments. The other implication is that we did see greater effects for adults with chronic conditions, and that's nicely consistent with the study by Guy David from 2015. All right, so I'm going to shift gears to our qualitative assessment for something completely different. So the qualitative assessment tried to address the question of what were the perceptions and experiences of primary care providers. How aware were they of this CareFirst patient-centered medical home program? which program elements were useful or not useful. And so here we assessed their experiences as of 2013 and 2014. We obtained information from written transcripts of 13 provider focus groups that were participating in the program, 39 separate telephone interviews, one-on-one, with physician leaders who could not attend the provider focus groups. There were also individuals in the practices identified by physician leadership as crucial, but those individuals were not initially invited to the focus groups, so separate telephone interviews were conducted. We also used in vivo software for coding our themes, and we worked with a multidisciplinary team. As I mentioned, Dr. Jay Want and Margie Roden, the nurse faculty member on our team, were involved in developing, reviewing the transcripts, developing an initial set of themes, and then revising those themes as we conducted the qualitative assessment. Okay, so this is hard to see, and I met with a UTMB faculty member earlier about qualitative research and mixed methods. So this is just an example from in vivo. So after discussion, we developed these sets of nodes, which are themes identified from reading the transcripts that appear over and over again. So this could include nodes such as the culture of the practice, leadership, the degree of engagement, mentioning workflow, quality improvement, the specific patient populations of interest, and then the specific elements. So how many times, for example, was the nurse care coordinator mentioned? How many times was the Searchlight data portal mentioned? How many times was financial payment mentioned? And as well as some of the other TCCI elements. Okay. And we had many different themes, too many really to summarize, but I just wanted to highlight several of the key ones that are most relevant to particularly this question of which program elements were most useful and least useful for participating providers. So our first key theme was that the increased reimbursement, that initial one-time 12% fee bump, and quality improvement were key motivators for primary care physicians to join the program. In the short run, it was helpful to build awareness of the CareFirst PCMH program, but improving patient quality of care and satisfaction was much more influential over the long run as a source of intrinsic motivation. So as we asked a year later whether the 12% fee bump was an important part of continuing to participate in the program, often the response that was consistent throughout the interviews and focus groups was that no, that was not important for long-term sustaining. And here's just a sample quote to illustrate the theme. So this is a physician from a large health system panel based in Maryland who says, "I think a lot of us are saying we're more driven by the quality, care plan, and quality improvement aspect of the PCMH program. This is in year 2 and year 3 than the financial incentives when they initially joined." A second key theme that came out, and this was really important, was the nurse care coordinators who played a critical role both in terms of awareness of the CareFirst patient-centered medical home program and also the tie-in to improving care coordination for patients. So nurse care coordinators were consistently perceived to be the most visible and valuable program element, and physicians in small practices were especially receptive to the support of having an external nurse to facilitate communications, in some cases follow-ups with patients. So here's a representative quote from a small practice that participated in the program. "We need someone like a nurse manager to help with complicated patients. That's very helpful for medication compliance, referral tracking, and checking in with patients. We just do not have the resources at this time to help very complicated patients with multiple chronic conditions." and that was a key source or target for the development of care plans by design in this patient-centered medical home model. Okay, and then our third key theme that came out was that most participating providers were unaware of the Searchlight data portal. Often when it was introduced in the provider focus groups, there were sort of blank looks of not understanding what the term meant. CareFirst, because there were problems with accessing the portal, they implemented program consultants to basically provide technical assistance to individual primary care practices to allow them to access some of the information in the portal. But in some cases, some of the physicians preferred having paper copies. They didn't want to log into the system. They found the menu difficult to navigate. They found the login procedure cumbersome. And so the program consultants would literally prepare summary reports in hard copy and deliver this to some of the clinicians. So only a few clinicians used the portal, which identified the top 50 patients with chronic conditions. So the navigation allowed you within the practice to see the sort of top 50 patients with multiple chronic conditions that were the highest cost, including specialist costs in the past year, as well as hospitalizations. And here's a quote from a representative quote from a small practice to just illustrate the theme. The remark here is, to be honest, I like things to be sent to me and pointed out. The portal is not the best option for me. I like it when the program consultant is here to show me things, but to actively go and put the password in and all these extra steps, no. And I don't know if the physicians who are dealing with electronic medical records, currently there are often woes in terms of accessing the system and pulling out information. Okay. All right, so from the qualitative assessment, some of our main main findings and implications. We found, of course, that the providers who participated in the program found the external nurse care coordinators to be the most visible and single most useful element of the patient-centered medical home program. Despite all these other services, despite all the other things in the bundle, that was consistent throughout the qualitative focus groups and interviews. Small primary care practices were especially receptive to the external care coordination resources. The 12% payment bump increased short-term awareness of the program, but did not really sustain a long-term engagement. And then lastly, the Searchlight data portal was in many ways the least useful of the program elements, mostly because it was difficult to access and navigate by most physicians. There would often be one person in the practice accessing the portal, and it may have been, in some cases, the office manager accessing the system. Okay, so as my dissertation advisor said, it's always good to go back to the original research questions and summarize what you found. So, summary of results. So did the PCMH program have any effect on total cost of care after 3 years? The short answer is yes. We found a small but significant effect, roughly 2.8% lower after 3 years compared to non-participants. On the qualitative question of what were participating providers' overall views of the PCMH program, generally they were positive, particularly for small practices that appreciated having access to some of the external resources. But there were some mixed views as well. And one I'll mention in particular, for the large integrated health systems, in some cases having the Searchlight portal or the external nurse care coordinator was seen as burdensome to an existing system. The other thing that was awkward for some of the primary care providers, and I'll mention the Johns Hopkins Health System, which is one of the largest ones in the Baltimore, Maryland area, because those primary care providers were getting information that referring patients to Johns Hopkins hospitals was very expensive or specialists affiliated with the Johns Hopkins system, they found it awkward to alter their referral patterns because they were owned by the Johns Hopkins health system. So there was some resistance among the larger integrated systems to the resources that were being offered by this payer. And then lastly, on the issue of which program elements were most and least useful for providers, as I mentioned, the external nurse care coordinators were resoundingly seen as positive, and then the Searchlight portal generally was found to be the least useful of the elements. Okay, we had a few study limitations, of course. So the findings are not necessarily generalizable to other adult populations, in particular Medicare beneficiaries. We were only focused on a commercial population of working age adults, 18 to 64 years old, or settings. So there may be unique aspects to the Maryland market, the District of Columbia, and that part of Northern Virginia that would may not necessarily translate to other areas of the country. Our qualitative assessments were limited to these 13 provider focus groups, which is a small sample, although we try to create a degree of representativeness by including a small practice, a virtual panel, a single independent primary care physician group with multiple physicians, and at least one large integrated health system as part of the qualitative assessment. And then lastly, for those of you who are familiar with program evaluations, you know this is the case. One of the biggest challenges is that the CEO of CareFirst continually made minor tweaks to the program. So, for example, introducing program consultants when he saw that the Searchlight data portal was not being accessed as frequently. That's something that came in 2012 and rolled out a bit in 2013. The external nurse care coordinators, in some regions, there was close to 100% staff turnover. Part of that has to do with commuting patterns in the local DC area and traffic, and the placement of the different practices attributed to nurse care coordinators. They implemented standard operating procedures and guidelines, so the nurse care coordinators had something in writing about expectations, and also they tried to align the location of the practices closer to where nurses were living, their own homes. These are examples, again, of other tweaks that happened after 2011. And there are many others. But in short, it's difficult to evaluate a moving target, and that was part of what we had to deal with as a challenge in this program evaluation. So in terms of some of the lessons learned, I'd say the most important, this came from both the more recent literature as well as findings from this study. And that is that targeting a patient-centered medical home program to individuals with multiple chronic conditions instead of everyone is more likely to be effective. The early examples of patient-centered medical home programs try to send a kind of bundle of services or payments to help all patients at large, all adults. And of course, it's not effective providing these resources for patients that are not accessing the system that often. And so one of the main things that we found here is that identifying a smaller group of patients with multiple chronic conditions who have greater needs is a much better use of resources for the program and increases the likelihood of finding an effect. And the second big one, it may take at least a year for a medical home program to have an effect on any number of outcomes. So therefore, some of the earlier studies that found null findings within a year are not surprising. But having these longer evaluations looking at 2 to 3 years is important to be able to detect a statistically significant effect. So I mentioned it took 1.5 years to clean the medical claims data. We spent a year going out into the field, conducting provider focus groups, the interviews, conducting the analysis of transcripts using in vivo software. And some good news, we have recent publications from this. So our quantitative results were published in the November 2016 issue of the Journal of General Internal Medicine by Alison Quayer, my colleague, Lawrence Humpkin. And then the qualitative article was published in the Journal of the American Board of Family Medicine in the December issue. And both are available. They're now in the literature. In terms of next steps, we're hoping to field a patient survey to try to identify patient experiences with care coordination. So this is a patient-centered medical home program, but the early emphasis didn't really focus on the patient-centered aspect of it. What were the patient's perceptions of care with the nurse care coordinators? What were the perceptions of patients who gave consent to a care plan? And so we're hoping to just get a basic understanding of how patients perceived this patient-centered medical home program. We're also doing follow-up qualitative focus groups to see if this moving target, in particular recent program changes in the last year, have had any effect in terms of awareness of program elements and general perceptions of the program. And then we should have, there's a delay in the claims rollout for 2016, but we'll include 2 additional years of claims data to see if the 3-year effects persist. And as I mentioned, we're looking at a number of quality-based measures, preventive screen analyses that are preliminary right now, and those we hope to complete those by the end of the year. So thank you very much for your attention. And what I'd like to do is open it up to see if there are any questions from the audience. I saw a hand up in the back.
Did you look on your claims data? Did you look to see if there was any difference in hospitalization rates or hospital readmission rates in PCMH patients with chronic diseases?
So yes, we did the analysis of hospitalizations, and we did find a small reduction in hospitalization use, also with ED use. It accounted roughly for about 40–50% of the reduction in the total cost of care. We're trying to sort of piece out what is the remaining aspect. It may be the services received after specialist referrals. But yes, we did that.
What is the turnover rate for the patient in this healthcare system? Like 2 years or something, 50% they will change their path. And it takes 2 or 3 years to have an effect, right? If they change their path within 1 year, 2 years, there's no need to implement this.
So I think the question is that in this case it took 2 or 3 years, right, to find an effect. So that was based on, so certainly within the CareFirst patient-centered medical home program, that's correct. The qualitative assessments helped to inform why it took a while, in particular the identifying patients with multiple chronic conditions took a long time, having the nurse care coordinators introduced to the practices took a while. I mentioned the 90% staff turnover issue, which was not trivial. And so in some of the regions, new nurse care coordinators had to come on board. And so those are some of the reasons why we didn't see effects until year 2 and year 3. Did that?
I think you could also say in the context of patients coming in and out of the program, that you only have to stay in the program like this for a year or 2. So in the context of that, if it takes 3 years to make effects, patients are only there for 1 or 2 years since about a year.
Yes. So in the analysis that I showed you, we have a group called the Always PCMH sample, and that included only patients who stayed throughout the 3-year period. There was some attrition with patients who fell out of the claims data or patients who moved out of the Maryland region. So there's our second analysis, we incorporated them in what's called the EVER sample, if they were ever enrolled. And those effects are pretty similar. They're a little bit higher in some cases, but the Always estimate is the more conservative one that keeps the same group of patients. Thank you. Yes.
Did you consider mental health as a chronic disease, mental health diagnosis as a chronic disease?
I think among the preferred set, so CareFirst identified within the claims data their target set of chronic conditions that were part of the basis for the development of care plans. I know diabetes, asthma are there. I don't think mental illness was included as one of the priority chronic conditions.
So you don't know what effect that had on the burden to the care coordinator or anybody if they had a lot of patients with that? You just don't know anything.
No, we couldn't observe that based on the claims
sort of a
data.
follow-up, with that combination of chronic disease, when you said 2 or more, did you find out if any combination mattered, like asthma with or diabetes with, or did any 2 seem to create more complex social situations or nurse care coordination situations or threatening to go to the ER?
So we couldn't observe social supports and some of the care coordination aspects in the claims data itself. We did find, and I can't recall which of the chronic conditions really mattered, but there were 2 or 3 that were higher priority where we saw a slightly greater effect in our robustness checks. But I can't recall offhand the exact specific ones, but there were certain chronic conditions that were especially important. You had your hand up for a while, so.
It's great to see that you're getting the perspectives of the actual patients to understand, what kind of barriers or, their experience with the program. However, have you guys thought about also coupling that up with their assigned case coordinator, because there may be system barriers or environmental barriers that may impact the relationship between the care coordinator and the patient?
So our initial focus for the patient survey sample with CareFirst is to highlight those individuals that already have a relationship with a nurse care coordinator. And in particular, we want to see patients that have completed the care plan throughout its full period of time. We know there are some patients who give consent to the care plan, but they only partially complete it, and they leave for whatever reason. They find they don't have the time, or they don't, quote-unquote, need the nurse care coordinator. So that's another group. And then there's a smaller group that we'd like to analyze that refuse to give they refuse to give consent to the care plans. It's much harder to get that group just because it's harder to track them on the part of CareFirst. But we're focusing specifically on those who already have an established relationship with a nurse care coordinator. Yes.
Along the lines of what Kathy said, I've worked within a care coordination program similar to this, and thinking about the resources available to different provider practices, did you find a difference between outcomes for those patients assigned to smaller practices versus those assigned to larger, which may have had more resources, like a mental health counselor to address some of those needs?
So in some of the analyses we did looking at different panels based on the size of the practice, we actually found a slightly greater effect on the smaller practices. That, I guess, we didn't have a strong hypothesis one way or the other. The qualitative interviews where we were getting some pushback from the larger integrated health systems suggested that the receptiveness to the nurse care coordinator would be less in those larger practices, and that was the case. But we saw stronger effects, stronger engagement with the smaller primary care practices. Yes?
I wondered about the non-participating physicians. Did she look at characteristics of their systems? I know that you mentioned that some of the ones that were participating, that the ones that were smaller practices tend to prefer some of these. But what about the ones that were excluded? And do you have any kind of inkling about the kinds of characteristics of their systems that may have made them reject the offer?
So we didn't have a systematic analysis to get at why primary care practice would refuse to accept the CareFirst patient-centered medical home model. From discussions anecdotally with participants in provider focus groups, because they often had colleagues in the local area who said they weren't going to sign up or join. Part of it had to do with patient mix. So in those practices where a relatively small fraction of patients seen were attributed to CareFirst, Blue Cross Blue Shield, that was a factor. It was not seen as worthwhile, even though you had this initial 12% fee bump. That was considered one issue. The other was Maryland, the state of Maryland had a competing medical home initiative. And the state required that if a primary care practice volunteered or voluntarily chose the state of Maryland's medical home model, they couldn't participate in any other privately insured medical home model. So all of those participants are in our comparison group, which, you know, it's sort of odd. We knew one of the evaluators of that group, and so we would talk to them because their evaluation was kind of on our comparison group, and they asked us what we were finding from this group. So just anecdotally, those were two potential differences, but we weren't able to do a very in-depth analysis of other reasons that would lead a primary care provider to not accept the offer of joining.
So you're saying that there was this other Maryland patient-centered medical home model, and some of the
comparison group, yes.
That. So do you think that may actually suppress some of the effects of measures?
So if anything, it should lead us more likely to a null effect, right? If the state of Maryland's patient-centered medical home program is doing a lot of the things, and again, that's an assumption. I don't know exactly what the core component elements were. But we would actually see a diminishing of effect, right? So if that program is strong. And the fact we did find a small but significant effect is somewhat reassuring news. Whether there's a difference in the two medical homes, I can't reach that conclusion. But it would actually suppress the likelihood of us finding effect. Yes.
Sorry, thank you so much for the great lecture. You may have touched on this. So if I understand correctly, this is more kind of the physician's aspect of how the PCMH is working.
Yes.
And I do understand that the outcomes that you looked at were, for example, hospitalization, pre-hospitalizations, or EDUs. What is EDUs?
Emergency department.
Yes.
Yes.
But did you actually, or maybe in the future, we will look at more patient-centered outcomes, for example, specific functional status or other health measure that perhaps in these PCMH homes are actually doing better off, or maybe they're doing worse off? So it's actually, part of the patient's experience.
Yeah, so we've embarked on the preventive screening measures, in part because we're limited. We're facing data limitations. So within the medical claims data itself, only certain information is being captured as to the types of services being used. Right now, there's no tracking of functional outcomes, and the claims data themselves are quite limited in terms of the information that's provided. So we're constrained by that. And for those of you who do research, you're aware also that claims data, it has its advantages administratively, but we don't have those types of fields. So unfortunately, that will not be part of the analysis.
I think we have to draw to a close. We want to say thank you to Dr. Gimm. We also want to say thank you.
Great. Thank you all for coming. Thank you. Yes. Really impressive. Because it was when we first discovered it. It was so amazing. know, right? Our initial thought was,
I thought I was going to follow up. Well, to me, that's it. And I didn't know, actually, just kind of when you're whispering, you're going to see in there, but did you go through that other mock?
Good job.
All right, thank you.
I mean, that's incredibly, the word is all the questions. I bet, I'll bet. Sure. You know, those children kinds of things. Your ambition is, your work was great, and I'm glad you did it. And I'm glad you keep following up with patients, because I think that's really the question.
You see it across.
I wasn't prepared for that. I got it. And that's like,
No, but that's where most of my edits are in, so I'll take care of there's, I don't know if you also sometimes more edits are coming.
and I also wasn't prepared. Was 600,000 people all assigned? No. Your treatment group had 600,000, 592, right? So rounded down. So 590,000 people were assigned care patients. Everybody in your experimental group got a care group.
I did, so then I can count.
So only ones out of that 600,000 who had multiple turnover were asked if they want. And then had to. So what percent of 600,000 people used care? And I wasn't going to ask you that in front of everybody. Well, even if you don't know, to me, that's your actual number. I mean, that's really the, as you're looking at what this model did, or was, the care coordination was big. Then what was it actually? Half of your